With myasthenia gravis, these pets can go from being pretty stable to being very unstable, needing to be on oxygen support and IV antibiotics. It can flip pretty quickly. I just feel like you have to be really honest with the clients from the get-go because this is going to be rough for the first couple weeks to a month or so, maybe even a little bit longer. But once you get there, it tends to be a lot easier.
Welcome back to VetFolio Voice. My guest for this talk is Dr. Downey Koos, who joined me to talk about a condition that I describe in this episode as one I see just infrequently enough to forget almost everything about it in between cases. Well, now that I think about it, that could probably describe a number of different conditions, but in this case, I'm referring to myasthenia gravis. So, as anyone else in the same boat and could use an update on how to spot this condition, how to diagnose and manage it, and how to answer the large number of questions the owners will inevitably have. Well, good news, Dr. Downey Koos does an excellent job of covering all of that, and we also broaden the conversation beyond myasthenia gravis to talk about other neuromuscular conditions like peripheral neuropathies, junctionopathies, and myopathies, and how there's a lot that we can do in general practice to narrow down the cause of our patients' symptoms and guide owners through treatment and referral options for conditions that in some cases can feel like they really don't always follow a straight line. They don't tend to do what the textbooks say they're going to do in a lot of cases. This was really a great episode, a refresher I definitely needed, so I hope you find it helpful too. Let me tell you a little bit about Dr. Downey Koos, and we'll go ahead and jump in. Dr. Downey Koos is a clinical neurologist at Blue Pearl in Franklin, Tennessee. She obtained her DVM degree at the University of Florida in 2018 and then completed a rotating internship at the University of Missouri in 2019, a specialty internship at a private practice in Los Angeles in 2020, and a residency in neurology and neurosurgery at the University of Georgia in 2023. Her professional interests include neurosurgery of every kind, epilepsy, meningoencephalitis of unknown etiology, and myasthenia gravis. This was a really interesting talk and really helpful, so let's go ahead and jump into it.
Things can get a bit chaotic in the waiting room, can't they? Don't waste time with clunky practice management software. There's a solution that just works. Say hello to ProVet, an intuitive modern system designed for the very best in animal patient care, empowered by the latest AI productivity tools. Your dedicated veterinary software since 2001. Find out more by searching Get Set for ProVet.
All right, well, I am really excited in this episode to be joined by Dr. Downey Koos, and we're going to talk about myasthenia gravis. And Lauren, thank you so much for joining me. This is something that I feel like we see just infrequently enough to forget everything that we know about it in between presentations.
Yeah, absolutely. I'm super happy to be here.
Yes. So let's just start with the fact that, kind of like I said before, these are cases that we don't see incredibly frequently. How common is myasthenia gravis?
Yeah, that's a great question. It is the most common neuromuscular disease that we see, but even then, neuromuscular disease is not that common. There's a paper from, I think, 1997 that looks at the prevalence of myasthenia gravis, and it's over 8,000 patients that they looked at with neuromuscular disease. I think it was like 13 or 14% of them had myasthenia gravis. So it is a good majority of what we see for neuromuscular disease, but even then it's pretty rare. And to my knowledge, there's not a paper that looks at a prevalence in terms of the entire population. That is an up-to-date number for the current population of cats and dogs we have in the world today.
Sure. So we're not looking at like the Addisons of neuromuscular disease, that we're just not looking for it. It really is something that it definitely happens, but that kind of perception of it's not something you're going to see all the time is relatively on track.
Absolutely. Yeah. No, I see it way more commonly because I'm a neurologist, but I think the average vet is going to see maybe one or two a year, if that. And I think there are going to be some vets that go like multiple years without seeing myasthenia gravis. Neuromuscular disease in general just isn't that common of things that we see. And so you mentioned earlier that you feel like you see it just enough to go, okay, great. I have forgotten everything about it. Like, absolutely, that's the case.
Oh, good. I'm glad that that perception is relatively accurate there and I'm not just like missing a bunch of cases. But with that being said, I do know that this disease can have kind of a variety of presentations and it's not always, kind of that textbook classic, the wind up toy type of presentation, that there can kind of be a variety of ways that we'll see this in practice. So, what are some of the things we should be on the lookout for to put myasthenia gravis on our differential list?
Yeah, absolutely. So it can come in multiple formations, really. The main two are generalized and focal that we see. Fortunately, the fulminant progression is pretty rare, but those patients are going to be the ones that come in with like flaccid paralysis. They can't really lift their head. They have become affected really, really quickly over the course of like 24 to 48 hours. And so, fortunately, those patients don't present quite as frequently as the generalized or focal versions do. But for generalized myasthenia gravis, you typically see appendicular weakness as the primary clinical issue, but you can absolutely also see regurgitation because those patients can get megaesophagus with myasthenia gravis. And so the more mild patients will look like they have a super short shuffled gait in all four of their limbs, and they might develop exercise intolerance where they'll walk for a period of time and then start to get shorter and choppier until they kind of fatigue out and have to sit or lay down. If you start seeing that, that should start, like turning the gears of, hey, myasthenia gravis might be something that I need to be worried about. And especially if you see that and they're regurgitating, that should be like top of your list of concern. However, patients that present with only regurgitation or regurgitation and a voice change can also have myasthenia gravis, and they just have a more focal version of it where it's only really affecting their pharyngeal muscles, their esophageal muscles, and so you might only see that. You can also see some cranial nerves be affected, and so like facial weakness can also be something that you experience where you can fatigue a palpebral reflex. So it can come as a variety of things.
Interesting. Can you see the voice change without the regurgitation? Like, can it affect the pharyngeal muscles maybe without the esophagus?
I guess theoretically it could, but usually if you have the focal version, the esophagus is the primary thing that's affected, and you may or may not have the voice change with the laryngeal muscles or the like facial weakness with your facial nerve. It primarily tends to be esophageal.
Sure, sure. That makes sense. So I really am not up to date at this point as far as treatment options for myasthenia because I understand kind of what I learned back in school really isn't even available anymore. So, what kind of treatment options are we looking at for myasthenia gravis?
Yeah, so the primary treatment is going to be some sort of acetylcholinesterase inhibitor. So pyridostigmine or Mestinon is the brand name. That is by far and away the most common version that you'll see. There are injectable versions with neostigmine or the Tensilon test. That is super, super, super short acting, and that doesn't exist anymore.
That's what I'm
Which,
thinking of that doesn't exist, not
yeah,
the treatments. I'm thinking of the
yeah.
Tensilon test.
Yeah, the Tensilon test doesn't exist anymore. They don't manufacture that drug, and so we don't have that as like a cage side diagnostic tool anymore. There's a paper looking at using neostigmine instead of Tensilon, and there's about an 80% response rate to that. So it seems to be pretty equivalent to the use of Tensilon, but it takes a longer time. Neostigmine is a longer lasting acetylcholinesterase inhibitor. And so instead of being able to see an effect in like 20 to 30 seconds, a minute later after giving the medication, you've got to wait like 30 to 45 minutes to see a response. But the paper suggested that up to 80% of patients that had myasthenia gravis would respond positively. So just because they don't respond doesn't mean that it's not something that should be considered anymore. But if you have a response, that kind of makes you feel pretty good about heading in the right direction. So those are the treatment options that we have with regards to replacing the ability for acetylcholine to last in the synaptic cleft for longer. But on top of that, there are other considerations. This is an autoimmune disease, and so the body produces antibodies for those acetylcholine receptors on the postsynaptic membrane. And if those are not available, then no matter how much acetylcholine you have in the synaptic cleft, you're not going to be able to transmit that information across to cause a muscular contraction. And so with autoimmune disease, you automatically go to steroids and other immunosuppressives, and those are absolutely utilized pretty heavily in some cases, but most people will start out with just pyridostigmine and then branch into prednisone, mycophenolate cyclosporin, other immunosuppressive medications based on how they're responding. You do have to be careful with using immunosuppressive medications and steroids because one of the big complications and risk factors with myasthenia gravis is the risk of aspiration pneumonia with their megaesophagus. With all their regurgitation, they just don't have a great ability to protect their airway. And so suppressing the immune system of a dog that has aspiration pneumonia can understandably go very poorly. So those are the main treatments, which I think those have, been around for a long time. But some of the newer stuff that we've been getting into is looking at things like human IVIG or therapeutic plasma exchange. And I'm particularly really excited about therapeutic plasma exchange. I did a lot of it in my residency, and while it's certainly not a magic bullet for a treatment option, I think it really helps the generalized patients that I've treated with it, and even the fulminant patients. I've had some fulminant patients that have gone from not being able to walk or even lift their head to being able to walk 24 hours later after treatment. So there's some really exciting options there now.
Absolutely. And listening to you talk about the treatment options, I'm glad you got into therapeutic plasma exchange because I want to talk more about that because that's where I really feel like I need to update myself on treatment options here. But I'm kind of realizing maybe I jumped over kind of the pathophysiology of myasthenia and the diagnostics. We talked a little bit about the tensilon test not being available anymore and acetylcholinesterase inhibitors. But for anybody who, is like me and doesn't see this very often, can you give us a refresher on what the pathophysiology is there and why we would use something like the tensilon test, which obviously we're not using anymore, or a neostigmine, like you're talking about?
Yeah, absolutely. So, myasthenia gravis, as I mentioned before, is an autoimmune disease. So, the body produces antibodies to the acetylcholine receptors on the postsynaptic membrane. So, at your neuromuscular junction, you have your axon terminus that stores little vesicles that have acetylcholine that live in them. And when you get an action potential that goes down that axon and you get depolarization, you end up getting an opening of calcium channels in the axon terminus, and the influx of calcium, it stimulates the release of those vesicles. So the vesicles will bind with that membrane, releasing the acetylcholine into the synaptic cleft, where they then have the ability to interact with your acetylcholine receptors on the postsynaptic muscle membrane. Once they bind, then that complex of acetylcholine and receptor will kind of invaginate into the postsynaptic membrane, and so it becomes not available anymore, which is then quickly replaced with other ones. And the acetylcholine is only left in the synaptic cleft for a very short period of time. Acetylcholinesterase is an enzyme that lives in the synaptic cleft that quickly starts cleaving the acetylcholine to reuptake it, to get reprocessed, rebuilt into new acetylcholine to then get recycled and used over again. And so with this process, with the autoantibodies floating around in your system, they will bind to the acetylcholine receptors, and then they will invaginate and not be available for binding acetylcholine. And the enacting of a muscle contraction requires multiple acetylcholine receptors to be bound to stimulate that. Just having one or two is not going to be enough to form a really good muscular contraction. And so you can see this fatiguing over time, or even if they are really severely affected where they don't have many receptors available to bind to acetylcholine, you can see this generalized weakness consistently where they don't even have a chance to fatigue because they weren't good in the first place. And so the reason why it impacts your esophagus in dogs is because you have striated muscle in your esophagus. And so wherever you have striated muscle, you can experience this neuromuscular weakness. And so that's why you end up getting megaesophagus and regurgitation with this disease too.
Sure.
And in terms of diagnostics, the Tensilon test used to be a really great diagnostic tool to have on hand. But as I mentioned before, we now have the neostigmine response test that's kind of taking its place since edrophonium is no longer produced. And that has about an 80% response rate. The gold standard, though, is to submit serum for an acetylcholine receptor antibody titer. There's really only a couple of labs in the world that run it. In the US, there's only one, and it's the San Diego Neuromuscular Lab with Diane Shelton. And so, regardless of if you send it to Antec or IDEX or send it direct, it's all going to go to Diane Shelton's lab for them to evaluate.
Okay, and that's why this therapeutic plasma exchange, that's where that comes into play because like you're describing here, we have these autoantibodies that are binding to our acetylcholine receptors and creating this musculoskeletal weakness. So when you're doing this therapeutic plasma exchange, is the idea that you're removing these autoantibodies and replacing with plasma that does not contain the antibodies? Is that
Correct.
correct? Okay.
Yeah. So it doesn't unfortunately do anything for the receptors that have already been bound. That's kind of an irreversible binding. You can't competitively overtake that. But the circulating antibodies, the idea with therapeutic plasma exchange is that you remove those. And so whether you're using a plasmapheresis machine or you're doing what I lovingly refer to as poor man's TPE, where you're doing it manually, regardless of how you do it. The idea is to remove enough plasma to remove that antibody burden that's circulating in your bloodstream so that you have fewer that will eventually make its way to the tissues to be able to bind to your acetylcholine receptors.
And how much plasma do you have to replace in order to reduce the autoantibody load enough to where you can help control clinical signs?
Yeah, so ultimately, the answer is kind of extrapolated from human medicine. There's only a couple of papers in veterinary medicine so far, but in human medicine, the way they do therapeutic plasma exchange is they calculate to replace 1 to 1.5 times the plasma volume over time. And so usually they're using the fancy plasmapheresis machines. They don't have to do the poor man's version. But ultimately, you make this calculation of here's the amount of plasma that I want to replace 1 to 1.5 times the volume that that dog has in their body. And then you calculate what that means for the total blood volume for you to have to replace. Obviously, you cannot replace that all in one go. You'd make that patient very anemic. And so you split it up into aliquots, usually no more than 20 mil per kg at a time, so that you're not making them clinically anemic. And you will pull that blood off, spin it down, separate the red blood cells from the plasma, and give them their red blood cells back. You don't have to go slow with this because it's an auto transfusion. It's their own red cells are not going to react to it, so you can give it over like 10 minutes. But then you do a plasma transfusion. Or in the case of really large patients, plasma is obviously very expensive and you need a really large volume to adequately replace everything drop for drop. So sometimes you do a combination of plasma and crystalloid fluids to try and help with that fluid balance as long as you're not dipping too low in your albumin levels. So it's a little bit of trial and error, monitoring them while they're in the middle of this process, making sure their protein's not dropping too low and that you're replacing enough plasma to be able to maintain their osmotic and hydrostatic pressures and making sure that you're not doing too much damage in terms of protein loss. But in those really large patients, I've done this on a Mastiff, which, as you can imagine, requires a lot of plasma. And
I
so
would
in
I would think so.
so in that case, we really only replaced half the plasma and the other volume we replaced with crystalloids, and it worked really well in that patient. But in that case, you're replacing that volume to dilute it out. And the calculations that are done is if you do 1 to 1.5 times a plasma volume replacement, theoretically you're more realistically replacing 67 to 75% of the plasma volume effectively. Since whenever you dump everything back in, it all mixes. It doesn't have like this part of my body has the new plasma. So
That's what I
I,
was wondering. I'm like, but you're putting it back in if you're doing it in aliquots, and so wouldn't you
yeah,
like that? That was kind of my what I was picturing. I'm like, okay, well, it's all mixed together now, but you're still, even though you're doing 1 to 1.5 times that patient's total plasma volume, I think what you're saying, you're getting the equivalent of, did you say 65 to 75%?
Yeah, roughly.
Okay. Okay. And that tends to be enough to get rid of enough antibodies
Yeah.
that your patient improves clinically.
Yes, absolutely. And honestly, I've seen it even sooner than that. So that Mastiff, we only got through half of her therapeutic plasma exchange session before she was up and walking around. And we said, okay, great. She did well enough. Maybe we don't have to do the other half. Maybe that was enough. You could go back and do the calculations to figure out exactly what percentage we did, but it was certainly less than the 67% on the low end. So that's what we refer to in the literature. That's what's most common in the human literature, but I just don't know if we have all of the studies to actually fully suss out this is exactly how much you need. And honestly, I think it's also kind of patient dependent. There's some patients that seem to be really responsive to it and others that haven't had as much of a response to it. And so maybe that therapy is just not the best option for them.
Sure. And do these patients, like, is this a permanent type of treatment or do they go on to remake these antibodies?
They will go on to remake these antibodies. So this is not a treatment that you can do in place of using pyridostigmine or steroids or other immunosuppressive medications. The goal is that you have to use less of them and that you get them out of that urgent situation and get them more stable sooner. But this is not a situation where it's a one and done kind of a treatment and then they're good to go. They're cured for the rest of their life. They still have the autoimmune disease, and so you still need to treat them appropriately with long-term long-term treatments, whether that ends up just being pyridostigmine, if that's enough and they don't need any other immunomodulatory drugs, or if you end up having a patient that needs everything imaginable, the goal is to try and help make them more stable in the short term, but they are going to start producing more autoantibodies.
Well, that is really cool. Just, to have multiple different options to help get them out of, like you said, that crisis state and maybe reduce the overall need for medications. Of course, with what you're talking about, treating with long-term medications and this not being a permanent fix, I know that there's an element of nursing care that goes into managing hospitalized patients, but also a lot of on the client communication side and owners being able to manage their pets at home. Can you talk a little bit about the nursing care aspect of managing myasthenia gravis?
Yeah, absolutely. So, whenever you're sending a patient home, that you might be sending a patient home that isn't walking if they were really, really severely affected to begin with. In an ideal world, they would be, but everyone's financial status is different, or maybe dogs don't do well in the hospital. And so sometimes you might be taking home a patient that's not walking. And so you have to do this recumbency care, nursing care of making sure that they have bedding that is well padded so that they're not at risk of developing pressure sores, making sure that we're taking them outside frequently to go to the bathroom. And if we're not able to get them out in enough time, that we're changing their bedding frequently so that they're not developing urine scald or fecal scald with any of those things. But even once you get to patients that are walking and you don't necessarily have to manage that, you do have to manage how much activity they have because usually the more exercise they have, the more fatigued they get. And so you kind of have to plan out here's how much activity they're allowed to have at any given time to try and make sure that they're not getting pushed to the brink of fatiguing and hypersalivating and regurgitating and doing all of those things again. One of the biggest components, specifically with patients that have megaesophagus as part of their myasthenia gravis, so this applies whether you have the focal version or a generalized version, is with megaesophagus, you need gravity assist to help get food down. And so you end up needing to use a Bailey chair or I've had some owners say my dog hates the Bailey chair. It makes them feel trapped. And so they just hold their pet in an upright position after they eat or drink. But going through that aspect of nursing care of they need to sit in a Bailey chair or sit in some way, shape, or form that keeps them upright for 15, 20 minutes after they finish eating anything or drinking anything, that massively changes how many treats that you give during the day, because if you're giving them a treat, then they have to sit upright for 15 to 20 minutes to make sure it gets down their esophagus and into their stomach. And there are some pets with this that their esophageal function seems to do better with more solid food or better with more liquidy food. There are some that really struggle with water, and so you need to use either like a thicket powder or hydrogel cubes to try and keep them hydrated and make sure they're not regurgitating and aspirating. And so a lot of it can be trial and error with the people at home, trying to figure out what their individual pet needs to be able to get adequate nutrition and adequate hydration into them.
Oh, these are some dedicated owners. I'm trying to picture like hydrogels on, this mastiff patient and how much of these different compounds it would take to help keep him hydrated. So I hope his TPE worked and he could handle water well, because that sounds like a lot.
Yeah.
But I mean, oftentimes we really do see the best in people in these cases. I mean, in the very rare case that I've seen a patient with myasthenia gravis, like these tend to be really dedicated owners.
Absolutely. And I kind of think that you have to be dedicated in order to be able to treat your pet appropriately and get them through this because there's a lot of things that can go wrong. And you have to be really on top of making sure that you're checking their breathing and making sure they didn't aspirate and get aspiration pneumonia, checking out do they look like they are fatiguing and starting to become exercise intolerant? How's their eating going? You really have to be on top of a lot of things. And so these owners end up being really, really dedicated to the care of their pets, and it's just yeah, you see a lot of really great things in people, and you really see a strong pet owner bond in these types of cases where they're just so dedicated to helping these pets.
Absolutely, absolutely. And what do we tell owners when we get the inevitable question, that obviously I want the answer to myself, when they say, well, what does this look like in the long term? What does the long-term prognosis tend to be?
Yeah, the long-term prognosis unfortunately is kind of guarded. There are some pets that can go into remission, just like you have any other autoimmune disease. You have a population that can go into remission and come off of medications. You have a population that goes back to normal but has to stay on drugs and would relapse otherwise. A population that is responsive to medications but is not going to go back to fully normal, and then a population that poorly responds. And unfortunately, for the pets that are still clinically affected, the risk of regurgitation and aspiration pneumonia still exists in a pretty powerful way. And so these pets can go from being pretty stable to being very unstable, needing to be on oxygen support and IV antibiotics, needing to have their mouths suctioned out with all the like hypersalivation they're experiencing. Like it can flip pretty quickly. So unfortunately it's pretty guarded, but usually the number that we quote is about 30% of them will go into remission. Somewhere in the 40 to 50% range will be either in the I respond and am normal as long as I'm on medications, or I respond but I'm not normal on medication. So responsive, just not going into remission, and then the rest of them are going to be unresponsive or poorly responsive to therapy.
So, one of those where there's certainly a chance that, we could get a really good response in these patients, but also cautioning owners that, there can be some more down the road. And like you said, sometimes they can do well and then take a turn, which, gosh, that is just heartbreaking to think about. So when you're talking to owners about all of this, the nursing care that's required at home, the guarded prognosis, things along those lines, do you have any tips for talking to owners about myasthenia gravis and kind of what to expect and what to be prepared for?
Yeah, absolutely. It's honestly not a fun conversation to
Sure.
have whenever you're having to deal with something that, these pets might be able to do really fabulously and go into remission and come off of medications and live the rest of their life no issue, but there's also a really strong chance that that's not actually what happens, and having to set those expectations at the beginning is, not a great conversation to have. It, Myasthenia gravis, while it is one of the things that I've become really passionate about, it's also at the same time one of my least favorite diseases to have to treat because when it goes poorly, it just goes so poorly and it's heartbreaking. And I just feel like you have to be really honest with the clients from the get-go and say, hey, listen, this disease process can sometimes go well, but it can also sometimes go poorly. And regardless of which way it goes, it's going to obligate a lot of at-home nursing care and a lot of monitoring and a lot of medications for you to be able to get these pets through this disease process. And I think just being open about the struggles is really important because I think a lot of clients might make other decisions if they knew how difficult it was going to be coming in, or they come back and say like, hey, like you really prepared me for this. This has gone way better than I expected it to go. And having those expectations of honestly setting a routine. I say the same thing for owners that come in with paralyzed pets and we can't help make them walk again and they need to be in carts. Setting a routine is so important for these owners because once you have a routine down, their pet like understands the routine, they understand the routine, and things become so much easier instead of you having to struggle to get them into the Bailey chair and get them set up and they're freaking out because they're not used to the Bailey chair yet. And now that they're in the Bailey chair, what do you mean I have to sit here for 15 minutes? I want to go play. I want to go nap. I want to go do other things. And so getting them used to that, getting used to whenever we're eating, honestly, doing smaller, more frequent meals tends to make a big difference. And so that ends up eating a lot more time for the owners, but setting that routine up of, okay, this is feeding time. This is the amount of time that we're dedicating to this. This is the amount of time that you have to be able to play and run around and live life as a dog before we're worried it becomes too much and that you might start fatiguing. And just having that routine set up makes things a lot easier. And I think just being honest with the owners about, hey, this is going to be rough for the first couple weeks to a month or so, maybe even a little bit longer, depending on how everyone transitions into things. This is going to be rough. But once they get used to it, I can't tell you how many owners come back to me and say, oh my gosh, like Sparky just like instantly gets into the Bailey chair and gets himself set up now. Or Sassy knows what, like, whenever it's time, like, okay, we're done with this. It's time for me to be able to go and run around and play and have fun. And that they recognize that routine. They get excited for the different parts of their routine, and it makes it so much easier. So I think just having that honest discussion of, listen, from the get-go, you're going to be doing a lot of nursing care. You're going to be giving a lot of medications. You're going to be doing a lot of trial and error to figure out what specific routine works for everyone in that household to be able to manage this. But once you get there, it tends to be a lot easier. And obviously you're still going to have to do the nursing care and still have to do all of the monitoring and following up, but it tends to be a lot easier once you set that.
Sure. No, that makes a lot of sense. There's that video. I'm sure there's multiple out there, but I just remember when they showed us a couple times in vet school of the dog running to the Bailey chair and getting in and flipping the little tray down, was like, I'm ready
Yeah.
to eat. And that's what I picture with Bailey chairs. I'm like, don't they all do that? And I'm sure they don't. But what you're saying makes a lot of sense in terms of, once you have that routine and they know, hey, if I go, sit in this chair, then I get food. And if I sit here long enough, then I can go play and be a dog again. I could see that making a huge difference and being a really important communication point for clients. Along the lines of client communication, we talked earlier about prognosis for these patients. If they do get a response and they get into this routine and they're like, okay, things are going well. Did I hear you correctly in that can change sometimes, that they can do well and then they can stop responding to medications?
Yeah, you heard that right, unfortunately.
Oh,
So yeah, I usually just temper the expectations of clients to say, hey, listen, I'm so excited that your dog is doing so well with this, and I really hope this continues, and we're going to move forward with treatments, assuming this is going to be the way this thing continues, but you cannot let up on your degree of monitoring with your pet. You have to keep a close eye on things because things can change. I, in my residency, had a dog that was diagnosed with myasthenia gravis from their primary vet, got started on pyridostigmine, dog went back to normal, and he presented with a generalized presentation. So he had the generalized weakness, he had megaesophagus and regurgitation, but he responded super well. and he went into remission, theoretically went into remission. They checked his level at the like 6 or 7 month mark, and immunologically speaking, he was in remission. And they were talking about, okay, do we start trying to slowly taper medications away? And they hadn't done it yet. And the next week, he started regurgitating again and then progressed really quickly over the course of about 48 hours to not being able to walk again and just represented with a massive swing into I'm no longer controlled. I'm no longer responsive to the protocol that I was on before. So unfortunately, that is something that has to be communicated is that while things are going well, amazing. We hope they continue to go well, and we're going to plan for them to go well. But I'm also going to, in the back of my mind, keep in mind that this might not go well continually and that we might reach a point where it stops being responsive and they start backsliding again.
Sure, sure. So just a tough management case all around from
Yeah.
the varying presentations to, getting the diagnosis and treatment options and care that the owners have to give at home. And then, if all goes perfectly, then we still are walking a little bit of a tightrope there. A case like that, it sounds like with all of the variables would be a candidate for referral to say, okay, I need you to talk to a neurologist about this who has managed these more than I have. But talk to me a little bit about that. Can we talk about the GP approach to neuromuscular diseases and, of course, myasthenia gravis in particular, but just neuromuscular diseases in general?
Yeah, absolutely. Myasthenia gravis is absolutely something that you can refer, but it is also something that you can treat as a primary vet, and you have the ability to get a diagnosis. So, in the realm of neuromuscular diseases, you have three big broad categories of disease that you can see and can look similar to each other. So, you can have a problem with the nerve itself. You can have a problem with the neuromuscular junction, like myasthenia gravis, or you can have a problem with the muscle. And while there are small differences between them. Like a Cushing myopathy is going to look a little bit different than a dog that has like immune-mediated polymyositis, or a dog with a polyneuropathy might look a little bit different. Usually they all look very similar, where it doesn't matter where along the motor unit you're having an issue, if you cannot transmit information from the spinal cord to the nerve, to the neuromuscular junction, to the muscle to cause contraction, you're going to lose tone, you're going to lose reflexes. And so they can all look very similar. So when you have a dog presenting with neuromuscular disease, you have to deal with all of these big categories of neuropathy, junctionopathy, and myopathy. But you can do a lot of tests as a primary vet to be able to rule out a lot of things. Any sort of muscular disease, unless that patient is so muscle wasted that they're just not producing much creatine kinase anymore, if you check a CK level and they have a myopathy, their CK level should be sky high. And I'm not meaning like a couple hundred elevated the way that a fractious cat can absolutely have. I mean, it needs to be like multiple thousands high. But if you have that, great. A myopathy is something that you need to be concerned about. If it's normal, it's probably not a muscular problem. And so then you can move on to, is it a nerve problem? Is it a junction problem? There are different metabolic issues. So you can get diabetic neuropathies. I just said Cushing myopathy. So you can get different endocrine diseases. You can get hypokalemia and hypocalcemia. You can have these different things that can cause neuromuscular weakness. And so by doing generalized blood work, you can pretty quickly start ruling out a lot of the metabolic causes. Checking a thyroid level because hypothyroidism can cause a neuropathy. It's pretty rare, but it absolutely can happen. And so checking those things, those are very easy things for you to do at your practice before sending it to a specialist. And the more of those tests you do, the better chance you have of being able to narrow it down. Unfortunately, you do eventually reach a certain point where you say, well, I've narrowed it down to these things and I don't have any more answers. Fortunately, myasthenia gravis is one of the ones that you can get an answer with because you have a blood test that you can do. Unfortunately, that's not a cage side blood test where you have a same day result. And so you have to send that out. And sometimes that comes back a couple days later. Sometimes that comes back like a week and a half later. And so often, whenever you are concerned about myasthenia gravis, That's when you start reaching for maybe I try a neostigmine trial to see if they have a response to that, or maybe I just put them on pyridostigmine to see are they responsive, and if they are, that gives me a pretty good clinical indication that this is myasthenia gravis in comparison to other diseases. But yeah, there's a lot of stuff that primary vets can do to try and work these pets up. But eventually, like if you get it down to this is either a junction problem, this pet has no ticks on it, it's not had any access to rotting carcasses or to a compost pile or anything where like botulism could be something impactful. And you're kind of ruling those things out. Eventually, you kind of get down to it could be polyradiculoneuritis, it could be myasthenia gravis, it could be a polyneuropathy if your CK is normal. And then at that point, you're like, well, I can either treat for the treatable or I can refer it to a neurologist that can do a further workup where we can do electrodiagnostic testing to try and give us a better answer for is this a junction problem? Is this a nerve problem? Unfortunately, there's no specific test. Let's say that you do all of that testing and you end up saying, okay, great, this is a nerve problem. There's no specific test for me to say this is a nerve problem because of inflammation or secondary to cancer or because of degenerative disease. And so sometimes at that point, you either need to look at biopsies, which are not the most amazing in terms of diagnostic results, or you do medication trials and you throw prednisone at them, which is the main drug that I use as a neurologist.
You get prednisone and you get
Yes,
prednisone.
absolutely. Steroids for everyone. And so if your owners don't necessarily have the means of going to a neurologist, you can do a lot of that workup and narrow things down pretty drastically before you reach a point where you say, well, I have these list of possibilities now. Here's our options.
Absolutely. I think that's really empowering to say, go ahead and go down the list. And then that way, even if they end up with referral, we still have all of this ruled out. And so that referral exam and workup can be a little bit more targeted. As far as the neuro exam itself, you mentioned botulism and myasthenia gravis, things like that, talking about lower motor neuron disease. Is there I feel like when you say this, I'm going to go, oh, yeah. And the answer is going to be obvious, but maybe not. When we're doing that neuro exam to kind of differentiate from nerve versus junction versus muscle, can you give us some pointers on what to look for?
Unfortunately, with neuromuscular disease, a lot of those look very similar. So
Sure.
you can make it be a clear answer of neuromuscular disease in comparison to some sort of spinal cord localization or intracranial localization, mainly using your reflexes, your tone, and to some degree your muscle atrophy that you experience in the limbs. And so if you see that the pet's gait is pretty short and choppy, very staccato in all four limbs. If you see that they are starting to experience muscle atrophy in a relatively short time span, if their tone in their legs is reduced where their their anti-gravity muscles that are engaging just there's not as much resistance as there should be whenever you're checking, or their reflexes are poor, their patellar and withdrawal reflexes are reduced. If you see that in all four limbs, that gives you a pretty clear answer that it is not in the central nervous system, and that is a peripheral nervous system problem. There is one exception to that, and that's if you have spinal cord disease at both of your regions of intumescence, so at your brachial plexus and at your pelvic plexus. Let's say you have like a disc herniation at both places, then great, you can look neuromuscular. But outside of that, you're going to be in the peripheral nervous system. This is going to be a neuromuscular problem. But the unfortunate part is that it doesn't matter if let's say I accidentally sever the nerve, or let's say that I have a muscle problem where I have a ton of inflammation in my muscles and that reduces the function, the capacity to be able to contract. It doesn't matter if I severed my nerve and I can't transmit that information down to my muscles to contract, or if I can get the information all the way there, but if the muscle's not healthy enough to contract, then it's not going to. The end result is the same with them not having much tone, not having many reflexes, and so often they will look similar. There are certain things where you can say, like, oh, polyradiculoneuritis shouldn't have a megaesophagus, whereas botulism and myasthenia gravis can. Cushing's myopathies, they're going to be really stiff in all of their limbs, and they'll still be short and choppy, but they'll be really stiff with their muscles, and they might not be as muscle atrophied. And so that there are small things here and there for each of the disease processes that you can kind of differentiate, but across the board, a lot of them look the same, which is why as an exam, you can say, great, this is a lower motor neuron problem. This is a neuromuscular problem. But now I have to start doing more diagnostics to try and figure out, is it a nerve problem, a junction problem, a muscle problem?
That actually makes me feel a lot better because I'm going, how do I differentiate these? But that's really helpful to know. You're going to get it to a certain point, and then there's other clues you can use, but it can eventually get hard to narrow down.
Absolutely.
And yes, and I love that we're talking about lower motor neuron disease too, because we talked before we turned the microphones on about, as fellow University of Florida graduates, there being 5 causes for lower motor neuron disease, not 4, because of course we have to worry about coral snakes.
Absolutely. Yeah.
Fortunately, an uncommon cause, but they're there.
Yeah. A lot of it is really regional dependent. And so like bufo toads can have a neurotoxin. And so if you're in that part of the US where bufo toads are a problem, then that has to be on your list of causing flaccid paralysis. Whereas if you're in Florida, coral snakes. And so, yeah, that it definitely changes what you end up looking for sure.
Sure. Well, Dr. Koos, this has been a great conversation. I learned a lot about, like I said, a disease that I see just infrequently enough that I feel like I need a refresher. And so this has been really helpful with a lot of information that I think feels really practical and kind of easy to keep top of mind. So thank you so much for joining me for this episode. Any final thoughts you want to share?
And I guess just as a summary of, yeah, this is something that you see infrequently, but you can diagnose it, you can treat it. If there's ever any concerns, please reach out to your local specialist. Even if it ends up being a pet that never comes to us directly, we are so happy to reach out and to talk to you guys about things and work our way through cases that might be a bit more complex, like neuromuscular cases can be. But these are absolutely diseases that are treatable within reason. And so, like, tempering those expectations and hoping for the best, but planning that this might not go well is unfortunately kind of the mindset that you have to use going into this disease. But I just think like communication is such a huge aspect of myasthenia gravis, whether it's communication with a specialist, communication with your owners, and just making sure that everyone's expectations are set up appropriately can really help the experience of dealing with this disease.
Absolutely. That makes a lot of sense. Thank you again for joining me.
Absolutely. It's my pleasure. Thanks so much for having me.
I want to say a huge thank you to Dr. Downey Koos for joining me. What a great discussion. And it was actually inspired by an article that she wrote in Today's Veterinary Practice called Acquired Myasthenia Gravis in Companion Animals. So if you want to dig in and learn a little bit more, you can go find that article in Today's Veterinary Practice. A big thank you to everyone who tuned in. That was a beefy discussion full of a lot of clinical information. So I hope you enjoyed it and learned a lot. I definitely did. If you did enjoy this episode, please leave us a 5-star review wherever you get your podcast to help other veterinary professionals out there find this and other great content we try to put out there. To find more episodes, you can click on the Education tab on the VetFolio website or find us wherever you get your podcasts. Of course, we'd love to hear your input on this episode, as well as ideas for topics you'd like to hear from us in the future. So feel free, reach out to me at dvm@vetfolio.com. We can also connect on Facebook at Dr. Cassi DVM, or you can find me on Instagram at dr.cassi.dvm. And remember, if one animal is better off because of you today, it's a great day.